Alright, so welcome back to my last episode about the colic. So this episode I'm going to talk about the medical management of colic in elephants. So the idea of the talk will based on the real case observation in elephants. So based on my literature research, that will be the current available technique of the treatment that lots of people in the elephant field do. For example, like in colic, many people do the enema, fluid and electrolyte replacement, walk by exercise. Someone even bath the elephants in the river, and say very common. Liver extract for like supplements, something like that. So I think so. Everyone know about this already, so I'm not gonna pass this. So my idea is the goal of my treatment, if I have to dealing with the elephant with colic, will be including three categories. The first one is relieving pain. The second one is correct the physiological imbalance, and the third one is stimulating or maintaining GI transit. So how can I relieving the pain in the colic? The first one is decompression. The second one is maintain GI transit, because one is moved, obstruction is gone, no pain. Alleviate abnormal GI contraction, especially with the spasm at the obstruction site. Decreasing inflammation, analgesic, and prevent shock from pain. Don't forget about this. Regarding with the correcting physiological imbalance, including definitely we have dehydration pattern, we have the pattern not eating, so it will be hypokalemic, and also could be acidosis. So think about that. And we have to think about ongoing pathological loss of the fluid and electrolyte in the intestine, and the adequate intake that worsening the condition, and also have to prevent shock from the fluid and electrolyte imbalance, especially when you have dealing with the non-strangulation obstruction and strangulation obstruction. Both of them can cause significant electrolyte and fluid loss in the intestinal tract. And there are also some pharmaceutical products that you can use in treating colic. So for my observation, there will be some special consideration about how to accessing the vein in elephants. In equine pattern, we access the vein by the external jugular vein, by the but we also have the same problem, because colic cases in horses, it's not one day cases. Sometimes it's stay with us for 10 days. Usually will develop phlebitis actually. But in elephant, I think we need to rethink about the catheter material and size, how to perform the catheterization, and how to take care of the catheter to prolong the usage, and how to prevent the complication caused by catheterization, including phlebitis, which can be worse, and thrombosis or an emboli, and the necrosis of the periphery of the ear pinna. We have to think about that. So in this special consideration, I think there will be some kind of like how to do the intervention that may prolong the catheter life. Could be like improving aseptic placement technique. I think we need to, if you need, we can go and investigate it and decide a better protocol. Keep the insertion site free from germs. So that another topic. The extension device from the catheter hub also help, because we don't have to touch much about the hub, which reducing the risk of the infection of the insertion site. Frequently flush with the heparinized saline. I don't know whether you do that or not, but this is definitely help. The topical application of the anti-inflammatory agent around the vein, that might be the novel idea. Once you start to recognize that there will be some change on the vein, you should replace it before the vein gets phlebitis. And I mean replacement is mean you change the place, not replace the catheter. And um, if we think out of the box, we should think about the alternative material of the catheter, like the central line and the pure catheter. So I have some video about this. So I think I'm interested in this actually, and I think I encourage you to try it. So let's take a look.
Central lines are very useful for patients who will be in hospital multiple days, those requiring frequent blood sampling, infusion of hyperosmolar fluids, or those requiring measurement of central venous pressure. A peel-away sheath with a stylet is inserted into the vessel. The stylet is removed, and a catheter is inserted through the peel-away sheath. The catheter will be inserted to a pre-measured level. Once it has reached that level, the peel-away sheath is snapped and gently peeled off the catheter. At the same time, the catheter is inserted more completely into the vessel. Once the catheter is completely in the vessel, it be sutured in place. The animal is clipped, surgically prepped, and drapes are placed. The drapes are being left off for visualization purposes. The clip should extend from the dorsal midline to lateral to the ventral midline, and from the angle of the mandible to the thoracic to an appropriate length, which is approximately the fourth intercostal space when using the jugular vein in order that central venous pressure measurement can be done. An imaginary line is drawn from the caudal aspect of the elbow with the limb in a neutral position up to a level that is in line with the venotomy site. The peel-away sheath with its stylet are inserted in through the skin and then into the vessel. The stylet is then removed and the catheter is inserted through the center of the peel-away sheath. Catheter is inserted to the pre-measured location. Once at that level, the peel-away sheath is snapped off the catheter and gently peeled away while the catheter is simultaneously inserted further into the vessel. Multi-lumen catheters come with 2 or 3 lumens. Each lumen is identified by its gauge and location. Is that fluid cannot come in or out of the catheter until the central valve is depressed. Blood should be aspirated to ensure appropriate location of the catheter, and then the catheter should be bandaged.
So the central line catheter is made from silicone, so it's more friendly to the vein, so it might stay longer. So I think this will worth to try actually. And the other consideration is about the flow of the fluid. In the past, I think about like 10 years ago, people, like when you have colic cases, you usually give maybe 5 to 10 liters of fluid, well, maximum 20, which is definitely not enough. And then we start to discuss about the amount of fluid and go to the bigger catheter, but still not enough. Now, if you can get 50 or 80, that's you good luck. But the elephants definitely drink more. So based on the Poisson law, you can know that the flow rate, which is V, is correlate to the radius of the catheter, and also the flow will be slower if the tube is longer. So this is the biggest catheter on earth, the 10G. I think maybe you want to try it. I don't know. So anyway, back to treatment strategies. So remember that we on about the let's see, the treatment. So how we can stimulate and maintain GI transit. So the strategy including the decompression, correction of the primary cause, like if it's obstruct, then you have to fix the obstruction. Use a pharmaceutical product to maintain the perfusion, like IV fluid, lubricating agent like liquid paraffin, or some people use the lactulose, and this is the dose that they provided. I never use that in my horses, but I know in cat, they use it for the megacolon. And you also can use the drug stimulating GI movement, which have to be used carefully because it can be produce a very bad negative effect. And you also can provide the mechanical stimulation like walking the elephant or bathing the elephant in the river. We call like shaking effect that will move the content and then stimulate the peristalsis of the small intestine. So, because the decompression and administering a lot of drug, for example, the liquid paraffin, if you want to administer in a large amount, it's I think like putting in the mouth of the elephant may be not adequate. So you need the proper technique. So I propose that you should try tubing under sedation with the mouth gag. And if you have the ET tube from horses or large animal that made from silicone, that also help, kind of like pre-tubing it. And then one is in the esophagus, you can insert the other smaller tube into that. So the technique is not too difficult in normal elephants. Um, if you brave enough, you also can try with the regular hooves that the end is being blunted, and then try with the blind technique. I prefer blind technique because I care my hands, but my colleague, she prefer hand insertion. So I think she is more braver than me. Regarding with the decompression in elephants, so this is questionable for the for the gastroduodenal. I don't know. For the excessive gas in high gut, definitely we can by the enterocentesis. By the excessive accumulation of the poop in the rectum, we can do by the hand evacuation, by the duodenal reflux decompression. I never witnessed with my naked eyes, but I know one person in advertisement perform and did it. Gonna we he did it. Um, so for the enterosynthesis of the cecum, so you can perform at the right para-lumbar fossa. It's located midway between the last rib and the ventral prominence of the tubercocci. And if you doesn't have ultrasound, you can do auscultation with your finger. You just hear the ping sound, ping, like that. And the equipment that you need will be 35 to 40 inches, about almost 1 centimeter of the cannula. And after you successfully decompress it with the gas, you should infiltrate it with the 100 to 300 ml of hydrophor like iodine to delay the growth of the bacteria again. So that will help extending the time that the gut will refill with the gas again. And some people afraid of the infection when the catheter being pulled off, but I don't. If you feel like you afraid of it, you can flushing the sunlight or diluted antibiotic while you're withdrawing the cannula. And there will be no requirement for systemic antibiotic after enterosynthesis. So this is some of the example equipment that I developed. So start from very scary ones, pretty big, and go to the stainless steel tube for coffee, and then the formal cannula. So basically the technique is really helpful. It's not the treatment technique, but it help preserving the life and allow you for a longer time to do to fix the primary cause. And this is, I should remember, I don't remember the name of the elephant, but I remember what time that I performed the enterocentesis in my first elephant. It's about 2 a.m. in the morning. And so next about systemic analgesics that can be used in elephant, maybe include the opioid like morphine and butorphanol, NSAID, especially the Flunixin meglumine, remember it's very potent analgesic. If you have elephant with colic and then you give a shot of Flunixin meglumine, colic sign is gone, it doesn't mean that you fix the primary cause. It just you fix the pain sign, but the problem is still there. So one of the common mistake that I want to underline is if you have the elephant with colic, you inject Flunixin meglumine, the elephant want to eat, don't let them eat because you still cannot fix the problem. So after a single injection, you should observe at least about 8 to 15 hours because the duration of the action is about 6 to 8 hours. If the sign of the pain is not coming back in, I would say, 8 to 10 hours, then you might fix the problem. The other drug that you might able to use is the local anesthetic drug. So the mechanism is we don't know. The rapid infusion increase the heart rate, but it's definitely helpful in some cases in past. And the drug that available is lidocaine. So regarding the opioid, maybe not the drug of choice because it produces a progressive movement. It reduces a progressive movement and also increasing the mixing movement and increasing the sphincter tone. So maybe not a choice. Butorphanol, maybe not too bad. It can be combined with the psilocin or ditomidine, and the doses in horses is here 0.5 to 0.1 mg per kg, or constant infused up to 23.7 microgram per kilo per hours. So there's also some effect on GI tract, the repeated dose leading to delay in intestinal transit. So you have to keep in mind, seem like it's not the drug of choice. Flunixin meglumine is a drug of choice for the visceral pain. It's one of the most effective drug that human ever invented for visceral pain for animal. It specifically blocks the thromboxane and prostacyclin. The effect lasts 8 to 12 hours after single dose. Reduce physiological response caused by endotoxemic. So this is the plus effect. Remember it high sign of pain, especially mild to moderate pain. And again, I have to underline that if you do the single shot of the Flunix and then the elephant pain is gone and want to eat, don't give any food to them. And after the single shot, you should observe for at least 8 to 12 hours after administration. The elephant that have colic and the pain cannot be controlled by Flunixin meglumine. It's the indicative of severe pain or non-medical colic. Like the other cases, NSAID is good drug, but also can cause side effect like GI mucosal ulceration, especially if you do the oral administration. I don't know anybody that give the oral doses of this one. This adverse effect is worsening if the animal is dehydrated, and remember your cases with the colic usually dehydrated. And the toxicity of the NSAID is increasing if you combine with the administration of the aminoglycoside like erythromycin or gentamicin. And chronic use may cause the alteration in GI motility. And remember, this drug, even useful, but it's toxic to kidney because it's excreted by kidney. When you have the pattern with dehydration, you have to look for the sign of toxicity closely. And definitely, this is non-specific cyclooxygenase inhibitor, so it delay GI healing. For the alpha-2 agonists, for the analgesic purposes, I know that you don't like the psilocin, but you have the ditomidine, seem promising, and it might allow you to perform some diagnostic tests and administration of the drug. For example, like once you see that you can do stomach tubing, and then do endoscopy, and then administration of the liquid paraffin, which is more, I think it's more suitable for obstruction, but totally depending on you. So there are also some adverse side effect of the alpha 2 agonist, like decreasing the heart rate, lowering cardiac output, increase the oxygen consumption of the intestine, reduce perfusion of the intestine, and may worsening the ischemic signs of the intestinal area, which in case in elephant I think is kind of rare. Dehydration status also can worsen the adverse effect of the alpha 2 agonist. And in case of colic, when you want to use the alpha 2 agonist, you may need to readjust the dose. The local anesthetic drug, this is pretty new to elephant field, is a prokinetic drug for ileus. It's a health stimulating GI motility and provides some analgesic effect. And in equine, we use the initial dose is 1.3 milligram per kg, followed by a constant rate of infusion 0.05 mg per kg per minute. To be honest, I never have a case that I can use in the horses. My first experience was in elephants. The mechanism that lidocaine decreasing inflammation is not known, but it may be due partly to preserving the microvascular integrity, preventing neutrophil migration, and also inhibit cytokine production. So in this topic, it's very interesting, inhibit cytokine production. If you have any diseases that provoke the cytokine storm, this drug might be benefit. So the effective for pain of medical colics, for example, like impaction, duodenitis, post-operative pain, this is all from the equine. Even the drug is a benefit, but it also have some toxicity. It's cause tachycardia, muscle fasciculation, erected hair, weakness, and recumbency. And all these adverse effect signs gone away pretty quick when you stop infusing the lidocaine. So the other drugs that you also can use is the IV fluid. We stick with that, and the fluid of choice is acetate ringer solution, spasmolytic drug, mucoprotectant, neostigmine, and beta-tonical, cisapride, neostigmine, stuff like that, metoclopramide. These drugs have to, even most people have a good experience, but you still have to use with caution because the forceful propulsion of the content into the obstruction site may make the obstruction more difficult to be corrected. The rupture of the intestine in this species seems to be rare, but remember when you're using the drug in combination, it will push all the content in the obstruction site even firmer, so that why it will be more difficult to be corrected. The other drug that you also can use is antacids like omeprazole or ranitidine. I think in human lately they prefer omeprazole because ranitidine seems to be carcinogenic. Regarding with the spasmolytic, it's reducing the spasm of the intestine, also affect the normal peristalsis, and the spasm can occur intraluminal at the obstruction site. And the available drugs, I think including Hyoscine, which is buscopan. Diaparon also has been shown to cause some effect on smooth muscle relaxation, but it's more on the airway and over the sphincter of Aldi in the liver. So Hyoscine or buscopan, also known as scopolamine, is a short-acting muscarinic cholinergic blocker, effective in relaxing smooth muscle of the GI tract and relax rectum, and help facilitate rectal palpation, perform easier, and also relax rectum and small colon, which help delay emptying time when you have to do enema in some patient that might benefit from enema. And there is no, it's not suitable for the ileus because it may lead into gas tympany and worsening the GI status. So for some of you may never heard about ileus. Ileus is the lack of movement of the intestine. So just a point to remember, buscopan even is a good drug, but in human medicine it is contraindicated in patients with eye problem like glaucoma and GI obstruction. I think it's because it worsened the condition. Regarding the mucosal protectant, so this is the best drug on the market right now, and we administer by the tube. And I found that if it's using the funnel, it's not convenient because it takes a long time because the duct poses very high viscosity. So the best way to deliver the drug through the stomach tube is you put the drug into the plastic bag and then connect the plastic back to the tube and then squeeze the drug into the tube. If you have a case that the bleeding like hemorrhagic gastritis, so there will be several methods that you can dealing with. The first one is prevent further mucosal damage by giving the mucosal protectant like this one, and the other thing is you adding the blood to the elephant, blood transfusion, and this is alternative drug. It's a Yunnan Paiyao, Chinese medicine to stop bleeding. So I still believe at this point most people prefer the conservative treatment because it's safe and blah 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 blah. You get used to it, but there's some point that you have to decide, when to go aggressive for diagnosis and treatment. Here's some of the experience that I can think about it. The first one is a decent abdomen with significant absence of the gut movement, because this will getting worse actually. The second case is extremely decent abdomen, but for this one you have to ask yourself whether you're gonna wait until this happen. Patient with heart rate more than 75 beats per minute, it's significant. It's indicative of severe pain. Drop in PCV without explainable reason, like in the case of hemorrhagic gastritis that we have. This one is a drop in PCV. Dark and putrid feces with indicated bleeding in the GI tract. The case that not respond to conservative treatment within 5 to 7 days, you have to rethink about it. Alteration in potassium and blood sugar, especially when the hyperkalemic, that's a bad sign. And if you're able to reach the final diagnosis that it is a strangulated obstruction, usually you have to call back hole to dig a hole. And this picture showing the aspirate from the stomach. It's kind of like reddish and it's blood from the case of hemorrhagic gastritis. So I have one cases report from India. So this case is about impaction. The abdomen can descend, but I think Thailand definitely win. So Thailand is bigger. And this case is the example of the case of the non-strangulation obstruction of the large colon that leading to the gastric gastric distension and hemorrhagic gastritis. So once it's resolved, all the feces being out and the smell is pretty bad.
วิดีโอนี้สามารถสื่อความหมายได้แต่ภาพและเสียงครับเสียดายถ้ามีกลิ่นได้จะดีมากเลยขี้ว่าเหม็นแล้วเนาะแต่ว่าขี้เน่านี่เหม็นจริง
And when it's being come out, it's just like waterfall. And so you can see the color of the feces is dark, and it's kind of like pathognomonic characteristic of the GI bleeding. And when the bleeding is in the stomach, when the blood is exposing to the acid, it's turned to the dark brown color. So that's pretty much all the colic that I can share in my little experience. So that will be the hot issue for the real equine, no, the real elephant practitioner to further think about it. What next when you have colic. So there will be some possible post-colic complication. The first one is the consequence from the prolonged hypovolemic. When the elephant have colic, the consequence of the enterocentesis or the consequence of the drug that you've been bombarding to the patient during the colic episode. We have to think about that, whether we might make the elephant is prone to kidney failure or liver failure, stuff like that. Regarding the phlebitis, seems like everyone kind of get used to it. So that's all I want to share, and hopefully looking forward to see everyone in the next few days, couple of days. And if you have question or suggestion, we can interact at the workshop. Good luck and hope you enjoy it. Bye.